So the next topic will be intrapelvic approach for the beginner, how to make it safe. Speaker Dr. Teshit from Queen Swang Watana Memorial Hospital, please.
Good afternoon, everyone. I'm Teshit Lilaseth from Queen Swang Watana Memorial Hospital. Today, my topic is a little bit basic for all of you. So I'm going to talk about the intrapelvic approach for the beginner, how to make it safe. Okay, so the outline is to understand the indication and anatomy of the intrapelvic approach, identify the key steps to make it safe, and also recognize the potential pitfall and complication. So what exactly the intrapelvic approach or the modified stop bar? It originally is described as an approach for the hernia repair by the stop bar, and then Cole and Bohefner modified the approach to fix the edema in the entry approach. Then it was also described in the Mayo by Keith Mayo in 2018 for the use it for the modification of the medial approach of the ilioinguinal. So he modified the medial window with the AIP or the modified stop bar and replaced it. So nowadays when we talk about the AIP approach, we should usually talk about AIP, that is the replaced medial window and also the lateral window that augmented without using the middle window. So the AIP indication for the AIP is to fix the anterior base pelvic or astomal fractures. The surgical exposure will expose the quadrilateral plate and also the posterior column without using the second window of the ilioinguinal. It's quite often we use it in combination with the lateral window of the ilioinguinal to fix the high anterior columns and the posterior column leg screw. So for the lateral window option, we have three options actually. If we just stop at the lateral window, we can expose only the internal iliac fossa. But if we need more exposure, we may open the inguinal ligament lateral to the psoas muscle to gain more exposure. Or we can also do the iliofemoral and do the ASS osteotomy to expand the exposure further. Okay, so this is the option to expand the green area of the fractures. So what makes AIP not safe or feel unsafe for beginner? Maybe it's from the complex anatomy and vital structures. There is a bladder, the corona mortis, the obturator vessel and nerve, and also the external iliac vessel. So to make it safe is to gain adequate exposure and visualization and how to apply the clamp safely without compromising these structures. So we always position the patient in the supine table and drape the leg free on the ipsilateral side so we can flex the hip and knee when needed to relax the psoas muscle and the external iliac vessel. The superficial dissection, we usually perform the curved incision about 1 or 2 fingertips superior to the pubic symphysis. And then we separate the rectus sheath vertically, high, and so we split it high to increase our exposure, and then we extend it low enough to release to the insertion, so we can have adequate exposure. Also, we have to be mindful of the bladder, which may be attached to the rectus sheath, rectus muscle. So we have to clear that out of the way as well. Also, we need the Foley catheter to decompress the bladder. So when we get into the space we call right chest space, we have to be a little bit more cautious about the extraperitoneal bladder injury. So it's possible to miss on the initial diagnosis about 20%. So if you see the gross hematuria, you need to be careful about this as well, using this approach. So we release the red duct attachment from the inside out, so we gain the adequate exposure, and we can put one whole man lateral to the rectus abdominis insertion. The corona mortis is the anastomosis between the inferior epigastric and obturator artery, which is the external and internal iliac system anastomosis. It could be found about 4 to 9 centimeters from the pubic symphysis. So here we can see that there is anastomosis between two systems of the vessel that we need to get it out of the way in order to get into the brim. So when we get into the brim, we will encounter another thing, which is the iliopectineal fascia, which we need to release to complete exposure of the pelvis. In order to do so, we have to get the external iliac vessel out of the way using the lever retractor, so we can go into the brim further. So, but be careful, even though you just get the coronal vortex out of the way, you have to be mindful of the anatomical variation, that is the bifurcation of the common iliac vessels, that may be a little bit more anterior in some patients. So be mindful that not to injure the structures when exposing the anterior SI joint. When we reduce the anterior column, it's quite important because the displaced anterior column fracture will bring the external iliac vessel to roll inside the surgical field. So we need to get it out of the way using the lever and also using the lateral traction of the femoral head. And then we can safely put the whole man so that we gain exposure. For the collet lateral plate and posterior column exposure, we need to release the obturator internus muscle so that we can access to the collet lateral plate. Also, we have to mobilize the obturator nerve and vessel proximally and distally by incise the membrane of the obturator foramen, so we can work around the nerve and vessel. And then we can put the clamp here near the greater sciatic notch. So to summarize the retractor position possible in this approach, first we have the pubic tubercle whole man, which retract the rectus abdominis muscle. The second one is the psoas cutter that we can place the blunt whole man in. The another one is the internal iliac fossa after we retract the external iliac vessels. Fourth one is the SI joint, which can expose the greater sciatic notch further. And the last one is the lesser notch. So we have many clamping opportunity for the AIP approach. So we can use either the Weber clamp or the pelvic reduction clamp based on the fracture line and pattern. We can also use a ball spike pusher and femoral head lateralization using a chance pin to help reduction of the quadrilateral plate as well. So here is a case. So this is a both column fractures that has a displaced quadrilateral plate or the posterior column. So we can use a pelvic plate in conjunction with the ball spike pusher to help reduce the posterior column. We can do this through the AIP approach, and then we fix it with a plate and screw. Also, we can utilize the lateral window using asymmetrical clamp or the collinear clamp based on the fracture configuration as well. We can also reduce the dome impaction through the AIP approach. So here we see that from the medial approach, we can see the femoral head, and here is this is a dome impaction. We can use the plier or the periosteal elevator to push it down to the femoral head to contour the dome, and then we put the quadrilateral plate, buttress plate, and fix with a screw. So we can also fix the quadrilateral plate and the posterior column using the intrapectineal plate or the quadrilateral plate buttressing. So this is quite, there is many variations that you can use. For summarization, so the key point for the adequate exposure would be the extension of the vertical limb of the rectus sheath extension and the inside out release of the insertion of the rectus muscle. The coronal mortis must be ligated in order to go into the brim. And we also have to identify the iliopectineal fascia and release it while protecting the external iliac vessels. Also, the displaced anterior column is making the external iliac vein close to the fractures. So we need to reduce the anterior column first in order to go further into the brim safely by using the lateral femoral head traction or the hip flexion. And we have to work around the obturator nerve and vessel to assess the conduit lateral plate or the posterior column. We have 5 reactor positions that we have to keep in mind so that we get an adequate exposure. And we have the possibility for posterior column reduction using multiple clamps. And lastly, if your approach is not enough, we can extend the lateral window using some extension like the ASS osteotomy. Thank you.
Okay, thank you for a very comprehensive lecture about the stop eye approach.